Good morning, and welcome here from New York at the Mount Sinai Fusa Heart Hospital. My name is Dr. Raman Sharma. I'm joined by Dr. Song here. We'll be your moderators for today. Just a few topics to discuss before we get started for the day. This is obviously our first broadcast of the academic year. So we'd like to welcome all the incoming fellows from around the country who are now joining. Their training specialties, as well as our three fellows here as well. Also, as I'm sure everybody has been getting the emails, we have our upcoming New York Endovascular Summit on September 11th, 12th, and 13th here at New York City. And we really look forward to you to joining us in this really interactive and educational summit, focusing on not just PAD, venous disease, but an aortic boot camp, as well as a podiatry session as well. There will also be, again, as always, for all of our fellows joining us, a dedicated fellows course. They'll also include a course competition, and we are excited to have your participation and excited to see all the abstracts and presentations you guys have. And remember, there are pretty awesome prizes. So that being said, we look forward to this interesting case that we're going to be beginning our first broadcast of the academic year. So, Dr. Krishnan, why don't you take it away and introduce everybody in the room and what we're doing today.
Thanks, Raman. Thanks, guys, and welcome again to the new academic year. So we have our team in place, and we're very fortunate again to have a couple of our esteemed colleagues to help us with these cases and really show different techniques and teach us. To my left is Dr. Rahul Patel, who's been with us multiple times, interventional radiologist at Mount Sinai, and really just a leader in venous and arterial intervention in Mount Sinai. To my right is Ajit Rao, who's been with us probably for every case for the last few months. He's been incredible in terms of really bringing the surgical perspective and also, how to manage things in a multidisciplinary manner. Both Rahul and Ajit, thank you very much. They're very busy and they take time out to come and help us teach and also for us to learn as well. Vishal Kapoor, this is his patient. So Vishal, thank you so much. And Vishal is the Director of Endovascular Services here at Mount Sinai Morningside. And we've got to introduce our new fellow. We have Michael, who is here. Michael has joined us from Stony Brook. We have three fellows this year, Michael, and Awad. And so it's a pleasure to have three of them join us in the program, which is wonderful. We have Ray Lascano, who's here. Ray's always here, has been here for every single case for the last 12 years of this program. And then we have Risa and Reika, who are nurses extraordinaire. And then outside, I believe we have Damien, right? Anybody else I'm forgetting? I don't think so. And we have our wonderful AV team as well. So we're ready to go. So we have a great case. So I'm going to have Michael present the case, and then Rahul and Ajit take it away.
So good morning, everyone. Like Dr. Krishnan said, we'll be doing a case of an IVC filter removal today. So the patient's a 61-year-old female. She is here for an IVC filter removal. She presented to the hospital earlier this year with a DVT and PE. She was started on Eliquis and then was discharged. Subsequently, she presented with symptoms of fatigue, being very tired, lethargic, and was found to have a hemoglobin of 3.7. She responded appropriately to blood transfusions. She received about 6 units. And she had an outpatient workup with an EGD and colonoscopy, which were unremarkable. She has now been, she also underwent a GI series, which was unremarkable, and she's been tolerating her DOAC well. As far as notable past medical history, she has hypertension, iron deficiency anemia due to chronic blood loss, DVTP and varicose veins, never smoker, and those are her medications down there. She's on Apixaban, Losartan, HCTZ, Metoprolol, iron supplementation, and a PPI. So as far as non-invasive vascular diagnostic study, she had a DVT that was found to be in the POP on initial presentation in February. And at that point, she wasn't tolerating anticoagulation, so we proceeded to place an IVC filter. So just some images of that.
I guess it's not working. Oh, there you go.
Oh, there we go.
Okay.
Yeah. This is a huge bug.
So this just shows the venogram. Vishal, you want to just talk through it?
Yeah, so we just did a venogram, getting our access, measured the IVC, make sure it falls within the realm of the dimensions which are appropriate for the IVC filter. We went ahead and deployed a Cook Select filter, which was a retrievable part. The idea knowing that because of our acute presentation of this GI bleed and a hemoglobin of 3.7, we wanted in the future to get the filter out. So after hematological consult and primary care and her tolerating Apixaban, we were sure that hopefully down the future we'll be able to retrieve the filter back, and that's why I saw her in clinic, very compliant with the medication, stable and cleared from GI perspective and hematology perspective to get the IVC filter out, and that's where we bring her back for round 2.
Okay, and then? All right, so why don't we stop there? And Rahul, maybe you can go through what your thoughts are, Ajit.
Yeah, so I think, this is, Vishal did a great job, making sure these patients get proper follow-up after filter placement, because a lot of these patients get sort of lost to the weeds, and their filters, they come back with complications from their filters, and it's a real thing, right? So filter thrombosis, penetration, and fracture. So if they don't need it, I think everyone's practice is to try to remove it. Again, I think for all of the interventionalists, we put them in, but we can't really take them out in a vacuum. So I think we did a good job here, following back with GI and hematology and make sure everyone's on board in terms of removing it.
So in terms of timing, Ajit, I mean, is there a time in which that you can take it out and a time when you can't?
Yeah, that's a good question. I think, you want to retrieve it as soon as it's, the patient's tolerating anticoagulation, they've recovered from whatever the hospitalization is. So ideally, I like to take it out within the first 3 to 6 months of, placing it. I think if you wait longer than that, like you have multiple issues that can come up. They can get lost to follow-up. Maybe they move somewhere else. Or, it just gets harder to remove at a certain point. And if the hook gets embedded in the IVC, that it can be a lot more challenging. So 3 to 6 months.
3 to 6 months. Yeah. So any workup or something you'd suggest before taking this out?
So, she's tolerating Apixaban. I think if you were going to do it in the sense of taking her off the blood thinner, or if she was not on blood thinner and she just needed to take it out, we would basically check an ultrasound duplex, maybe a D-dimer, just to make sure there's no sort of ongoing clot issues. But, patients who are tolerating blood thinner, there's not really a lot of workup other than maybe a duplex if you're concerned that there's extension of clot or that the blood thinner is not working.
And how about the filter itself? I mean, do you need a CT? Do you need an MRI?
So that varies a lot. I think there are places that will get a CT scan on patients to have filter removals. I think if they're not on blood thinner, I think it's worthwhile just to make sure there's not a lot of clot in the filter. We'll check today, as we do with every filter removal, to make sure there's no massive amount of clot in the filter before removing it. But no, there isn't really much imaging if they're on blood thinner, especially if in the short term. If it's been years and years, then we would probably get a CT scan just to make sure, or an X-ray or something just to make sure it's not tilted or fractured. But in the short term, we usually don't do a lot of pre-op imaging.
So, Raman, any questions about anything before we go to the procedure?
Yeah, I mean, I think this is a very well outlined case. As far as indications of filter removal, I think the fallacies in people's follow-ups is where we find all the challenges. And I think Vishal, as always, very thorough, making sure that we do catch these people. I have one question now. This is obviously not the case for today, but how do we, I'm sure we're going to be discussing this at some point, but what about the patient who had the IVC filter placed in 2000, had some Greenfield filter that was put in, and now for the first time in their life, it's not as if that they just came in and they have symptoms of like lower extremity swelling or something that's more venous related, but they have true abdominal penetration symptoms. Like, how was there any pre-workup for that? Any imaging that you would do beforehand?
Yeah, so on those patients, we'll do a CT venogram to see exactly what's penetrating, to see what kind of filter it is, and then, obviously if it's fractured or broken or if there's clot inside the filter. Those patients that have sort of the non-retrievable filters, even though we call them non-retrievable, other than bird's nest filters, and we have taken one of those out before, most of them you can actually take out. You can rip them out. Then it's sort of a risk-benefit analysis, right? So if the patient's asymptomatic and they've made it 25 years without having any issues and they're on blood thinner, I would probably say just leave it alone, depending on their age and sort of their other medical comorbidities. If every so often we see a relatively very young patient that has had a greenfield or some other type of non-retrievable filter that was placed years ago for maybe trauma or in some sort of trauma setting where they've had its clot, obviously a provoked DVT or no longer on blood thinner. And then it's sort of a different conversation in saying like, I can't really project out 40 years what's going to happen to this filter, and then we sort of just see what the patient wants to do in terms of removing it. Most of them we can remove relatively safely, but it's not 100% safe to remove those filters.
And Ajit, what are some of the ancillary equipment that you're going to need when you're planning this? In terms of what are some? I know snares are very common, but any particular types of snares, things like that?
Yeah. I agree completely with Dr. Patel. I think it really, just like many other things we do, it comes down to like planning. So in this case, and I don't want to jinx us because we've said it 10 times, it's only been in a couple of months. So I'm assuming this is going to be a relatively straightforward, more on the straightforward side. But if a filter has been in for 5-10 years, in that case, I'm going in with that, with all the equipment, and you should really have it for any filter, retrieval in the hospital, but, I'll have it in the room. So I'll have forceps, and there's some other techniques we can talk about, hangman is another kind of trick that I do, or ballooning it off the IVC, which I know Dr. Kapoor did recently, and then getting femoral access in those cases too. So going into it, I'm kind of planning ahead in terms of my access and my equipment.
And is laser something that people need to be very...
So people have published on using the laser sheath. I know the group at Stanford's even published on exactly how much force you should really be applying. They spent a lot of time doing sort of force measurements. We typically have not needed to use a laser sheath, but some people swear by it in terms of especially ones that are scarred into the IVC, using it to burn. I find it's more so that the sheath is just very rigid, and that it allows you to sort of blunt dissect the legs off the filter. But some people swear by this laser, and I'm not going to fault people for using it.
And when you talk about the complications, obviously filter fracture, fragmentation, embolization, all those, what are the chances of perforation in these scarred-in filters?
So it can happen. Most of the times, the IVC is a low pressure system. It tends to be small. I think a lot of it is just making sure that you really sheath over the filter and bring all the legs in, and then trying to pull it out. Some people will, not get it fully sheathed and then try to rip it out, and then you'll end up the legs will tear and sort of lacerate the IVC. But I would say every couple of years we see one where we end up having to put a stent graft in, more so on the non-retrievable side than the retrievable side. Yeah.
And when you talk about a stent graft, you talk about just the aortic cuff, or you talk about the entire system itself?
Yeah. I've only had one so far. That was mine, but I had to put in a TVAR. It was a very large, the IVC is comparable to the, aorta in terms of sizing, and is there bigger.
Any predictors of that people need to watch out for?
Some filters are more prone to it than others. So obviously the nitinol green filters, the ones with the sort of the wavy legs, those ones tend to get scarred in a lot more. The trapeze filters can as well, but we've seen it even with just especially like really tilted, really embedded filters. If you just can't get it in the right angle, you can end up ripping it through the IVC. Again, with that in terms of Ajit was saying about having the right equipment. The other thing is if we think that's going to happen in certain cases, we'll make sure we'll have an aortic occlusion balloon ready. Sometimes again you can just press down on the patient's belly to get a little bit of hemostasis, but you just want to make sure you have it around so you're not like running around the hospital trying to find an aortic occlusion balloon to get temporary hemostasis until you can figure it out. Sometimes just putting up the balloon and sort of holding it for a little bit is enough, but you have to balance the anticoagulation and the possibility of clot formation as well. But yeah,
that's kind of my algorithm too. Like if we do see a perforation, sometimes we'll just leave up the occlusion balloon. If you leave it up for 10-15 minutes, if it's a small perforation, because it's a low pressure system, a lot of times you can that can seal off potentially. And then in the cases where, the IVC is just completely disrupted and it's still bleeding, that's the time where I had to do a TVAR to seal it up.
And let's talk a little bit about DOACs. A lot of these patients are on DOACs, and do you do it on anticoagulation, off anticoagulation? Any recommendations by the societies?
So from the IR Society, the recommendation is actually to leave them on blood thinner. That being said, if you want to transition them, off the DOAC, put them on Lovenox, then stop the Lovenox for the day of the procedure, that's fine. I think for a lot of our patients, even the more complex ones, we'll actually leave them on blood thinner. If the ones that are really complex that we're gonna have to rip it out with using forceps and stuff, we will transition them off on Lovenox temporarily during the procedure.
Same with you guys, or?
Yeah, I think this is just, my preference is just to have control over the anticoagulation. So if it's a straightforward one, I think continuing them on it is fine. But if it's a more complex one, I like to have control, so I'll stop it, 2-3 days before, and then give heparin during the case, and that way I can reverse it if I need to.
So Rahul mentioned filter tilt a couple of times. Explain to the audience in terms of when you're talking about filter tilt, is it something that we did wrong while inserting it, or is that something that happens during the process?
That's a good question. I think a lot of times it's, what you're going to get when it's deployed. So actually, if it's something that I didn't do, I'll actually look at the older films, or if I need to refresh my memory, because that also gives me an idea of whether it's going to be, what the chances are that it's stuck to the wall. So I think a lot of it is just in terms of the placement, kind of right away. If you're very technically skilled like Dr. Kapoor, I'm sure this is going to be right in the middle of the IVC. But
no, we did one with the what you may call it, the angulation and tilted. I think the biggest factor in that is the axis. But if you go from the right common femoral axis, because it's more in line with the IVC, and if you do it the right way, it's hopefully aligned straight out. If you start to go from the left side, there's a chance that it tilts, because the way you unsheath it, it might just cause a deviation or just a tilt towards the opposite contralateral side, or it goes from the other side.
Yeah, absolutely. And then some of the filters are designed to be deployed over a wire. I don't think this one is per se, but some of them you can put an Amplatz wire through and try to straighten out the IVC deployment. The other thing is the IVC is not a fixed structure, right? So as you breathe, as you walk, as you move, the IVC stretches and twists and pulls and stuff. And so some of these filters, just because of the way they're designed, that motion will cause them to tilt and filter. And so, some of the very old BART filters are no longer on the market that you probably see, like the advertisements, find your lawyer kind of advertisements. Those filters were known to tilt, or what would happen is you actually get retrograde movement of the filter, and so the legs would penetrate because it would actually sink down into the IVC, and you would get penetration into the valve, spine, and things like that.
So if you see, let's say you deploy a filter and you see whether it's tilted to one side, do you take any intervention measures at that time to realign it, or just leave it and say, I'll take care of it when I'm back to retrieve it, which is a better position?
So we usually just leave it, unless it's obviously completely, flopped down or turned. But yeah, we just leave it, because to remove it then and to remove it later is going to be sort of the same hassle. So we just leave it, and then we'll deal with it when it comes time to remove it. Yeah.
I think that makes sense.
All right. Anything else, David, Raman? And we can maybe show the equipment?
Yeah.
So in cases where there is debris in the IVC filter, how would your procedural algorithm change? Would you go with thrombectomy up front, or if you could share your experience with that?
Yeah, so we typically see debris on patients that are not on blood thinner. So what we'll do is we'll give them it depends on how much. If it's just a small amount of debris, sometimes you can just take it out and it'll come with the filter. It's usually like a fibrin cap or something like that on the filter hook. And so we'll just take it out, and it'll be fine. If there's a decent amount of clot in the filter, especially underneath the filter, or a long tongue of clot above the filter, we'll put them on blood thinner. If it's a lot of clot above, we may convert to a thrombectomy, and just so then it's just sort of your whatever thrombectomy device you kind of want to use. But if it's just a little bit of clot, we'll usually just take it out.
As far as thrombectomy device, anything in particular you like better?
We've used them all, and they all kind of work. So it just depends on what you kind of like.
What you like, and what's available in the lab.
What's available in the lab. And then also, some of them are different sizes, right? So if you use a penumbra, it's 16. If you use the Inari, it may be up into like a 24 French. So then it just depends on your level of anesthesia and what the patient will tolerate in terms of access and things like that.
Yeah. I had one 2-3 weeks ago where I did a iliocaval DVT and put in a filter beforehand, and then when I brought the patient back, there was a good amount of clot, and so that one I was kind of expecting, potentially that. So I had femoral access, and I just ran a penumbra underneath the filter, sucked out as much as I could and then retrieved it.
Yeah.
So
Yeah, some of that will be just stuck onto the filter, so it'll come out with it. You know.
So deployment-wise, to get back to Vishal's question, is an IJ deployment favored over a femoral deployment for tilting issues, or no?
No, I think for us, we find that both I agree. I think the right is easier and it tends to make it more straight, or right IJ. We've done left IJ just in certain patients that they're occluded, but I think they both are can make them relatively straight. The one thing I think it looks like the Cook one has like the little button you press. So from the IJ approach, if it's not totally straight, you can actually yank on it a little bit to kind of straighten it from the IJ approach. You can't really pull it, but you can kind of like yank it a little bit straight if you have to. But other than that, I don't think it really. Yeah, I think then it's just patient preference and sort of what their condition is.
And also what the lab does.
Yeah.
I do think if you deploy it on the lower side, sometimes the sheath is a little more biased, and then you can get more of a tilt. So you really want to make sure you're well into the IVC, around the renal veins.
And tilting increases the chance of penetration and difficulty in retrieval.
Yes.
Is that fair?
Yeah.
Okay. All right.
Cool.
So, Raman, if you're okay, we're just going to go through the equipment and show the procedure.
Yes, please.
All right. So let's focus on this, guys, for Dr. Patel.
So I don't know if you guys can see this. So this is the Clover retrieval set from Cook, which is actually just a whole kit. So it's 3 pieces. It's an outer, so this is the light blue piece, which is the outer 10 French sheath. Then you have the inside, you have a dilator, and then you have an inside, which is this dark blue, which is, I believe, a 7 or 8 French guide cath. So what you're going to do is it's sort of a triaxial system. You have a sheath, sort of an inner guide, and then you have the snare catheter here, which comes all sort of prepared.
Can you zoom in on this, guys? Here, let's
Actually,
go.
yeah.
Here. There you go.
Yeah, so you can see it's a tri-loop, a nice tri-loop snare, and then it has a torque device on it, so you can get around the hook there.
Yeah. So basically the sheath and then the snare through the sheath, and then you're gonna hook it with the
Yeah.
snare.
So basically you hook the filter in here, you kind of lock it down, and then this black piece won't slide over the filter, but then the idea is then you take this dark blue piece.
Yep, we'll bring it over here.
Yeah, the dark blue piece, and then you slide that over the filter. That typically doesn't get over the legs; it gets you down to the feet of the filter, and then you sort of use this light blue piece to slide that down further.
So like telescope it over.
Yeah, exactly, and that gives you a lot of pull. So once you get both pieces down to the feet, if you have to sort of yank a little bit to get it out, it'll pop out.
Now, do you do a venogram before and after?
Yeah, so we always do a venogram before and after. We always take a look at the filter before as well, just to make sure it's not fractured in the interim. Also to get a sense of like, okay, is it really tilted? And then we'll do a venogram as a post just to make sure there's no injury to the IVC.
And any role for IVUS?
No, unless you're worried about something, residual clot or anything. Yeah, we haven't really done IVUS. I don't know, Ajit, if you...
No, I don't routinely use IVUS. I have used it like patients that like had contrast allergies or something if I'm trying to just assist with placement, but for retrieval, rarely.
Rarely, okay. And in terms of wire, what wire does it go over?
So it's an 035 system, so you can use whatever 035 wire. I mean, typically we do it over an Amplats or a relatively stiff wire. The one thing is these transitions here between these two pieces here aren't super great. So the other thing is to make sure you dilate well at the neck. So we actually put in a 10 French sheath to start in the neck, just to make the dilation easier, so then you can the transition will be easy to get this thing in. But I think our plan was to put it over a supercore.
Supercore is fine.
Yeah.
Okay.
Yeah.
Well, fantastic. Let's go. Let's get it done. That's great.
Let's
go.
let's go.
Vishal, go ahead.
Yeah. So let's see if we can switch to fluoro. I'm gonna fluoro real quick. Yeah. So as you can see, there's the filter. Let's see. I'm gonna take a single shot here just so you can see it better. Here you go. Oh, this doesn't work?
Yeah, no, it'll work. The center one.
Yep, center one.
So there you can see the filter, and that's actually a pigtail catheter from the neck. So you kind of get a sense of the direction of the IVC, and Vishal did a great job placing the filter. So you can see the filter seems relatively straight, but we'll do a cavogram here.
You want to do the cavogram now?
Yeah.
And let me just set it up.
Yeah.
Hold on, let me center it.
Yeah. Oh, sorry, you want to...
Ready?
Yeah.
Okay. You guys are doing this on heparin?
No, we didn't...
No anticoagulation, Roman. We're just doing it on right now with no anticoagulation.
Yeah.
Okay, want a better one?
The patient's
want a better one?
current outpatient
Let's go better one.
anticoagulation, correct?
More die? I'm sorry,
Like
Roman.
10 for 20
You broke up.
Yeah, so using the current
1100.
anticoagulation the patient is already taking.
Yeah. But we stopped that anticoagulation, Roman.
Yeah.
So there's absolutely no anticoagulation at this stage.
Yeah, so there you go, nice cavogram, right? So you can see it's fairly straight. Again, you can get sometimes fooled because straight, obviously it's a 2D. We don't necessarily do an oblique just to see, but unless we have difficulty removing it, then we'll do an oblique. But here it looks relatively straight within the lumen of the IVC.
And you're looking for the two borders of the IVC. That's why you wanted us to do it again?
Yeah.
Okay. Because everybody at home, like in this one, you can see we underfilled. You can't really tell the borders very well. So Dr. Patel made us do another one with 10, 20, 1100 PSI, and you can see clearly the borders of the IVC very clearly.
So based on the venogram, Rahul, can you comment if there's any of those prongs going through the wall? Like, what's the feature you will look for based on the venogram?
So if there's a subtle penetration, you're not going to be able to tell, right? So, and obviously the posterior and anterior ones, you're not going to be able to tell. But that being so obviously, if it's really beyond the borders of the IVC, you can tell. The other, sometimes people will say that if it looks like it's more open than the IVC, so the filter looks like it's sunk down, then the legs may be penetrated. The one thing I would say is penetration is obviously a concern, but there's actually good data to show that even if it's penetrated, the legs are penetrated into the aorta. Smaller vessels are a little bit trickier, but really the one you worry about is the aorta. That you can actually still remove it without too much issue. That it doesn't really cause problems.
In those cases, do you get arterial access?
So it depends, right? So sometimes you'll see it where it looks like it's in the aorta, but it's just like pressing, because the aortic wall is relatively thick, right? Compared to the IVC. So if it's just like touching, I don't, but if it looks like it's actually in the aorta, I will. I've never actually had to do anything, but it's just one of those things. Like I'm guessing if I didn't do it, something's going to happen, and then I'm running. So just to put a little catheter in the, a 5 French catheter in the aorta, just to make sure is not a big deal.
Very nice. All right.
In that same topic, if you had to, kind of make some sort of guess here, that most lateral prong seems to be beyond the wall.
Yeah.
So, given the overall stability of the patient and the chronological time period here that we're talking about, where would you, if you had to guess, where would that prong be? Do you think it's perforated through the wall? Is it in a small vessel?
It's more likely in a small vessel, or that's probably what's going on. But in reality, it's not super far. Technically, the aorta does go on that side, but I'm not really super concerned.
What did you do?
Suddenly, my good work is looking.
But
they reconsider the deployment.
And the other thing, also, especially with this filter, is it's good to understand exactly how these filters are designed. So when you take them out, you make sure you get all of it, right? So like this filter has the legs that actually touch the aorta, or with the anchoring legs, and then it has those stabilizing legs as well. So when you take it out, you want to make sure you have all of those pieces. Where like an option filter only has the legs, that just the legs, as opposed to the stabilization part too. So just making sure you get everything.
And I guess the final question before you go is: are all IVC filters created equal?
So the data would say yes. I would think there's preferences. People have preferences. IVC filters 15 years ago, there was a lot of buzz and movement around filters. I think now it's become sort of a commodity product. So it just depends on like what you're used to and what's cheaper, or what's what your
and what the institution
decides to go with. Yeah.
So you don't see one superior to the other in any way.
We have a preference, I think, but I think they're all basically the same. They all have their own sets of issues and things. They do have some idiosyncrasies in terms of when you do remove it. So like this one, it's welded together at the very top, whereas like the option is a single cut laser piece of nitinol. So if you do have to say come from the groin and try to rip it out, like this one will fall apart, right? Okay. Whereas the option will also fall apart, but it's less likely to do that. So if you have to come and sort of rip it out from below, which we're not going to do today.
No. All right, let's get going. We're getting 30, so why don't we get the wire down and let's get started.
Yeah. Perfect.
Yeah. Let's go.
I normally use this.
You made 300 supercore?
Yeah, to get a stiff wire implants, supercore.
Yeah. And do you bury the supercore all the way down in the iliac, or?
Yeah, just somewhere distal. Yeah, I mean, it's gonna have to obviously come out when we take out the filter. So
sure, naturally.
And then, Rahul, what's your kind of like escalation pathway? Like, obviously we're starting with the retrieval kit, but if that's not making progress, what's your next step?
Yeah, that's a good point.
Yeah, so it depends on why it's failing, right? So sometimes if it's tilted, then we will. I tend to go sort of just from time standpoint.
You got the monitor there too, Rahul.
Oh, thanks. Yeah. I tend to go with just the forceps. The problem is right now is the no one's making the forceps, so
Yeah.
they're hard to get. And they do have fatigue, and
Take
so
the
some of them
sheath
are. You got the wire?
Yeah, I got the
Sorry.
wire.
Do you ever utilize like a hangman technique or ballooning it, or do you go straight to forceps?
Can you describe the hangman technique for everybody?
So we've used the hangman technique before. It depends on the type of filter and why it's failing, if you can get underneath it. So the hangman, basically you loop a glide wire underneath, so use like a sauce or some sort of reverse curve catheter, and then you have one end obviously outside, the stiff end out, and then you basically snare the front end of the glide wire, and you've created your own sort of lasso or hangman.
You got it. Good. So you basically lasso it with the glide wire.
Yeah, we actually may end up giving
You
her
want me to
heparin.
go
Nick?
We may end up giving her heparin. She's forming a clot here.
Okay. Can we give her heparin, please?
So we're giving heparin now?
Yeah, give.
Yeah, she's just forming clot on the wire.
Yep, so we're going to give heparin. How much heparin are we going to give?
At least 10. She's 180.
10,000, please.
Yeah. Sheath is right there.
All right.
So I'm going to go a little bit past just to make my life a little easier.
Yeah.
And then we're going to take everything out the wire and dilate her out.
So, heparin, 10,000 of heparin in, guys. Okay. Do you attach to dye or anything? Oh, no, not at this stage.
No.
Okay, good. Let's put it on coronary.
Yeah.
And if you could mag up a couple.
Yeah.
Oh, I have it here. I don't know why I'm looking over there.
There you go.
There you go. So this is the...
So you have the two markers. Talk about the two markers.
Yeah, so the distal marker, or the smaller marker, is the inner guide cath. That's is the first thing that's going to sheath over. The more proximal marker is the marker for the actual 10 French sheath.
Got it.
And then this is the snare coming down. So typically now I can bring everything back.
And the point of the dual sheaths is really so you don't lose access, right? That's one of the reasons.
Yeah.
So you can pull the filter into the inner sheath and then leave the outer sheath in there.
So that's the snare coming down, and then, let's see.
So you're snaring the body of the filter and then pulling it up to the hook?
Yeah, exactly. So
let me just see that. Oh, it's on DSA.
Here.
Put it on coronary, guys. 1 second, Rohit.
yeah, sure.
Is it on corner?
Is it on coronary?
Good.
Okay, there it is. Okay.
So you can see sort of that technique that we used. I think if you go for the hook first, it tends to be a little bit harder. So I tried to snare the neck, making sure I'm on it, and then sort of open the snare a little bit, and then sort of brought it back up to the hook. But
And then do you rotate the snare in any way, or it should?
it depends. So if it looks like it's going right on top, I won't. Sometimes if I'm not getting it, I'll rotate the snare to see if I'm interacting with the filter, and then you can tell like if it's sort of like the filter sort of moving away from the snare as you're rotating it.
Right.
It's like the snare is pushing away the filter. It means that it's tilted. So you can either use like an angled guide. This catheter, the snare catheter that comes with, has a little bit of angle, so you can kind of use that angle to sort of manipulate the filter into a different plane to try to get around the top of the filter.
Beautiful.
Do you ever use like an angled sheath or something?
Yeah. So I actually brought one. It's like I usually like a 7 French Envoy or like an angled guide cath.
And you just manipulate it.
Yeah, manipulate it. Sometimes you can. So in terms of escalation, if it looks like it's just a little tilted, you can use like an MP guide even and try to like sweep and try to sweep it off the wall. You know, if it's a little tilted, you know, you can try to use a balloon, especially depending on how it's tilted. You know, the ones that become more complicated, if it's like tilted into the roof of the renal vein, those ones become a little bit more tricky to get out.
So when do you in escalation you start with the snare, then you do the hangman technique, then you go to the forceps. Is that kind of how you go, or is there a particular algorithm you follow?
Yeah. So again, just from time standpoint, I know the forceps will just cover right there. The forceps will always get it out. So it's we'll tend to just move straight to the forceps. But again, we've had these situations. Again, like I said, they're not always available because. I think in Mount Sinai system, I think we have 3 total. One may actually be broken, or they might be being sterilized because they're reusable. Wow. So you have to be. You may not always have it, so you have to be ready to try maybe the hangman.
I think that's kind of one of the more risky ways to remove it too. You have to be experienced to do that, because if you can rip the filter to pieces, and then it's going to travel to the lung and become a much bigger problem. So, so I agree with you, but I like to, if I can, if it's just touching the wall, I'll do the hangman or try to balloon it off the wall, and then actually go back to snare just to try to avoid the forceps because otherwise I have to call you.
And the forceps, can I ask you, trying to take it out as a whole, or does it come out piecemeal only?
So ideally, you like to take it out as a whole. When we do it, so you can also remove them from the groin, which is obviously a super aggressive maneuver because you're basically inverting the filter. Then sometimes it'll come out in pieces. But then what we'll do is we'll come from above and below. The other thing you can do is actually, if you don't want to rip it out, you can come from below, grab it from below with the forceps, and then straighten it, and then snare it from
top,
above, and then pull it that way. So you can do a lot of different maneuvers. I'll be honest, it's been a long time since I've seen a filter I couldn't get out, but it can happen. So
Yeah, of course. Absolutely. And then any maneuver you would avoid, like twisting? I mean, when do you twist? Because we often, the twisting can obviously cause sort of a torsion.
You can twist to a degree, right? Like you can rotate and try to use, especially if you're trying to use the sheath to sort of blunt dissect the feet off or the legs off.
Right.
You can use you can twist. I wouldn't do so like full on rotation.
Yeah. Okay.
All right.
All right. So here we are. So what the next?
So I don't know if you guys can.
Well, we're gonna. Why don't you pull that out? We're gonna radiate Dr. Patel a little bit here. So show Dr. Patel's arms, guys, if you can, with the camera.
Yeah.
Can you bring the? There you go. At least you can kind of see. There you go.
So you can see. So basically, I don't know if you can zoom in here.
Can you zoom in on his hands? Yeah, there you go.
Yeah. So this TUI is actually on the back of the of the snare kit, and so what we've done is we've snared it and we've got tension. And so what I've done, some people will just tighten the TUI. I find that just tightening the TUI to lock it isn't usually enough. So we just put a little hemostat here. So then basically what I'm going to do, instead of working the filter or the snare, I'm going to work the filter, the catheter for the snare, and then try to use that as a rail.
So put side by side, guys, Dr. Patel's hands and the screen. Thank you. So he can talk through what he sees on the screen. Okay, there's the screen.
So I'm going to pull back a little bit, right, to give me tension. And then this doesn't want to go. So then...
So what doesn't go?
The inner sheath.
Inner sheath.
Yeah.
Okay.
Oh, there it goes.
Okay.
Oh, no, that's the...
Maybe the TUI was too tight. Yeah.
But in that case where the inner sheath catches the hook, do you put the outer sheath first
there you
to
go.
try to collapse?
Yeah, exactly. So I put the outer sheath first, and then I will slide that one back down.
So why did you go back and forth there?
Again, it's just trying to build up tension and stability within the removal system, right?
Right. So now the IV. Now what? How do you know the IVC is not collapsed now?
It is.
It is.
Yeah.
Okay.
Yeah, because the feet aren't in the system.
The wall.
So, so now it's just a matter of seeing.
So I always get a little afraid when I'm doing this because
you have. So a little bit. That last little bit you have to pull. So again, do you
cycle a cuff, guys? I know Raman's laughing.
But you do have to pull. If you haven't done a lot of these, you do have to pull hard when you're.
You do have to pull fairly hard, yeah, and it's especially in the beginning, it's a little uncomfortable of how hard you have to pull. Again, like I said, the Stanford guys have done like this study where they actually put like a force meter on someone's hands as they were pulling and came up with like how much newtons you can pull. I don't know what that means. Someone has too much time on their hands, but So but someone's looked at it like how hard you can really pull. So I'm actually going to just remove the filter sort of this way.
So for everybody at home, blood pressure is stable, 130 as it was.
Yeah, it comes out right there.
And there it comes. And
show
the filter, guys, for everyone. Maybe a little higher. There you go.
Yeah.
To Dr. Kapoor. There you go.
Yeah. A little bit more.
A little bit more.
Yeah.
There you go. So what now Ajit and Rahul, are you looking for parts of the filter?
Yeah, we definitely look to make sure we have all of it. Again, this one wasn't super hard to get out because Vishal did a good job placing it. We didn't have to do a lot of maneuvers, but sometimes if I'm not sure, or especially if I do get it out in pieces, I'll also make sure I take a single shot of the lungs at the end just to make sure there's no pieces in the lungs.
So can you show us here, like, what are the anchors and what are the talking about?
This is as we talked about before. So these are the feet of the filter. This one actually has the hooks that sort of keep it.
So the hooks are the anchors.
Yeah, the anchors right here. And then these bars here are meant to stabilize or
keep it centered.
Keep it centered, right? So it's to stabilize the filter within the.
And you're saying the options. This doesn't exist. Only these exist.
No, the opposite. So this only exists and this doesn't.
Okay. Wow.
Yeah.
But you always want to make sure everything's there by examining it, and then also on fluoro. And then what would you do if you did have like a leg that was still in the IVC? How do you manage that?
Yeah, so it depends. So if it's penetrated, if it's outside the IVC, then do you have a little flush?
Oh, you want to flush? Yeah,
sure. Just make sure.
Then we're gonna do a venogram.
Yeah, I'm gonna give him the. Yeah.
Would you leave it alone if it was?
Yeah, so it
extravascular?
depends, right? Like if there's a, sorry.
No, it's abdomen.
If there's
That's fine.
if it's truly outside the confines of the IVC, then obviously we're going to leave it. A lot of times we'll try to get it
Ready?
Yeah.
Okay, let me just fill it a little bit. Let's fill it. Okay, ready?
DSA.
Yep, DSA.
Yeah. Looks good.
Beautiful.
Yeah. So
All right.
so back to Edge's question. So yeah, if it's inside the IVC, we'll try to remove we'll try to remove all of it because
With
those
forceps or
Well,
what
yeah,
would you do?
yeah. So it depends. So we'll try, if we have the forceps open, we'll use the forceps. Sometimes we'll even switch back to the snare. The snare is about 20 some odd millimeters in diameter, maybe a little bit more. So depending on the size of the IVC, if you just sort of run it up and down, it'll catch the filter. We have bigger triple loop snares as well, so they go up to like 34 millimeters if the IVC is really big.
And how do you deal with the hemostasis of the neck? Just manual pressure?
Just manual pressure. Yeah.
So no suture, nothing. You don't do mattress.
No, I mean if we have to put a 16 or 18 French sheath in, we'll put a suture to hold to get hemostasis. But for this is just a 10 French sheath in the neck.
Yeah, absolutely.
Yeah.
Okay. Well, if there's any, I'm going to have Michael has prepared a quick presentation, a couple of slides, and as we finish up, when we have Rahul and Ajit still here, why don't we do the quick shots and we can make some comments?
Yeah.
Go ahead.
Can we get
Slides,
the
guys?
Slides back up, please. So we'll talk briefly about venous thromboembolism and IVC filters.
Yeah, we can take it all out. You don't have to put the wire back down. You can just pull it.
So as we all know, VT accounts for about 555,000 hospital admissions per year. You have some of the filters on the right. We kind of briefly talked that they come in different forms. 30%. There's a 30% recurrence of venous thromboembolism within 10 years. Anticoagulation is always the first line approach to prevention and treatment. And just some history. That the first IVC filter was the Uden umbrella in '67. And there's actually a paucity of randomized data to support IVC filters, but we'll talk about 2 trials that were done. So one was done in 1998, it's the Pre-operative trial. They basically looked at patients with PE, preventing PE in patients with proximal deep vein thrombosis. So there were about 400 patients that were randomized to anticoagulation plus filter or anticoagulation alone. And you can kind of see some of the results. So there really wasn't any significant difference except for recurrent deep vein thrombosis was actually higher in those with a filter. So there was some reduction of recurrent PE, but it came at the cost of having higher DVT recurrence in those with filters, and there really wasn't any difference in mortality. Now, after the retrievable IVC filters were around in the early 2000s, they did another study, the Pre-operative 2, which looked at if there was any difference with retrievable IVC filters. So this is in patients who were hospitalized with DVT, who are at risk for PE. They also had PEs. And the plan was to put the filters in for about 3 months and see what the results were. And again, you can see, straight down the line, there really wasn't any significant difference with recurrent PE, DVTs, and there really wasn't any difference in mortality as well. So just societal guidelines, you have ESC on the bottom, you have American College of Radiology and AHA. And CHEST guidelines also revised theirs in 2021. And basically, we all agree on the same thing that, patients with DVT with contraindications to anticoagulation, like this patient had, or active bleeding should receive an IVC filter. And anticoagulation should be resumed in these patients with an IVC filter once the contraindications to anticoagulation or active bleeding has resolved. So, the filters are not benign like we had all discussed, and they shouldn't just be put in left and right. It should be patients who truly have a contraindication to anticoagulation, and they should be removed as soon as feasible. So a lot of the societal guidelines, we all kind of agree on that. And just a nice little thing for IVC filter placement with traffic lights. So the green on the left hand is you should proceed. So those who have absolute contraindication to anticoagulation, if there's a complication of anticoagulation that requires discontinuation, or failure of anticoagulation. So these are kind of a nice little diagram showing certain scenarios.
Excellent. Excellent job. Just a question for Ajit and Rahul and even Raman and everyone is, when you're doing iliac DVT, I mean, there's a controversy about putting in a temporary filter and taking it out. Some people say, some guidelines say don't do it, some people do it. So what is the current thoughts on that? Would you do a temporary filter while you're doing suction thrombectomy, et cetera, et cetera?
Yeah, so I think it depends. For me, it depends on how extensive the clot is. If there's clot in the IVC, then either we'll put something to temporarily protect while we do it. So there are other devices that are out there that are meant to just be temporary. People have even used a wall stent, like half-opened wall stent at the top of the IVC to sort of protect during the procedure, and then you can obviously take that out. Or if you don't want to do that, you can also just put a filter in. For left-sided DVT, especially in patients with May-Thurner, and it's just all iliofemoral, I've tended not to put in filters.
Yeah, I agree with that. I think
so. Just extent of the clot.
Yeah, iliofemoral. In general, I don't think you have to, as long as you're careful with your technique, which is a big factor. Anything that goes into the IVC, I think, is much higher risk, and in those cases, I will put in a filter. And then the other thing, like Rahul mentioned, is Inari has like a disc, that you can temporarily put up as well, and that can.
They also have a sheath too, the Protrieve sheath, 20 French Protrieve sheath. Boston makes this smart claw you can use as well, just temporarily, or the wall, like I said, the wall stent. People have used like an Amplatzer plug as a temporary. I don't like that idea, but people have used it as a temporary occlusion.
Yeah.
So there are different ways you can manage that. The other thing is, we talked about sort of retrievable filters. There are actually filters now that are designed to be temporary, to offer temporary filtration, but eventually open up. So
bioabsorbable.
Bioabsorbable. So I think BD makes one where the center hook has a stitch that dissolves over time and it pops open. There's also one that's like that you can pull the hook. So you basically go in and remove that hook and the thing opens up. So you don't have to remove the whole filter. You just remove that little hook and the thing pops open. There's a company called Adient which actually has the whole thing is bioabsorbable. So it's designed to about 3 months or so that the whole thing goes away.
Wow.
So yeah. So there are. I wouldn't say there's no filter, changes in filter designs, but there are. That's basically where they're going is trying to do that.
Very interesting. Yeah.
All right. Well, Raman, I think that was a great discussion, and I think any questions from you guys? I think we're pretty done here. I think everybody's said what they had to say. Any thoughts?
Yeah. I think that was. A lot of discussion. I would have actually. I'm not saying that facetiously. This is the case that we all come across very, very often, and I think that it's good to have such an elaborate discussion as far as every single point, because ideally we like to be in a situation just like this where it is straightforward. We don't have to do any of this funny hangman's business, and ripping out is something that there's always a little bit of concern when you're talking about doing any of this stuff. So I think it's nice that we had a demonstration of a very, very straightforward case. A lot of great discussion.
And what we'll do, Raman, is we will find one that's maybe a little more involved, and have Rahul come and demonstrate some of those cases. Because I think showing hangman, showing these techniques might be something very valuable, and we'll do it as an escalatory style. Obviously, this one was a 3-month filter, and maybe we could talk to Rahul. He gets a lot of these patients. Maybe we can demonstrate one as well to show a little bit of a different approach for our colleagues.
Outstanding.
All right. Well, thanks again. I want to thank Rahul. I want to thank Ajit for taking time out of their schedule to be with us. Rahul, thank you. It's always so well received, and thank you very much for taking your time. So with that, Raman, we'll sign off from the lab, and then we'll go ahead and you finish up.
Sounds good.
All right.
Thank you to Dr. Krishnan and the team for a wonderful case as always. Our next live case will be Wednesday, August 27th here at Mount Sinai. At August 13th, my correction. And then for any, we have an extensive library of live cases always available on YouTube and the CCC live case website. So always please reach out to us for questions, and thank you for joining us as always. Take care.
All right. Thanks a lot, guys.